Now, let me ask you this, because I'm over here in the United States, and there's some doctors over here that are resistant to UAE. Why do you think that is if you're getting results like this?
Right. Okay. It is not unique to the United States. This is in Australia as well, and in many
Oh,
parts of the country. Okay.
okay.
So I guess there's a few things. Number one, as at least in Australia, I think it will be not too different from the United States. If a woman with heavy menstrual bleeding, period pain, the first protocol is the family doctors, right?
Okay.
They
Uh-huh.
go and see the family doctors. The family doctors will try some simple measures, maybe the pills, maybe the marina, and things like that. And then that hasn't worked. The next step is quite often, at least in Australia, it's a very low threshold for the GP to refer on to a gynecologist because it is, after all, a woman's health issue.
Okay.
Yeah.
Yeah.
And gynecologists, they are trained to do things like marina IUD,
Yeah.
hysteroscopic resection, marina insertion, and of course, all of them are trained to do hysterectomy.
Okay.
Okay,
Yeah.
so that's what they're familiar with. That's what they train to do, and that's what they making a living on.
Okay.
It's very fair in United States as well. In Australia, we very fair. It's like a fee for service. If you don't work, you don't get the income. You
Right.
have to do some work. You have to offer a service to derive your income. So we tend to offer what we can do, what we're familiar with. That's what happened. So give you one example. And again, adeno is relatively new, and fibroembolization has been around for more than 25 years,
Okay.
right? And in Australia, we still do 30,000 hysterectomy a year. We have the highest hysterectomy rate in OECD country. We do 250 per 100,000 women per year.
Wow.
So give you a sense of comparison, in Denmark, which is another OECD country, it is much smaller in geographically, but otherwise very similar to Australia in terms of GDPs and life expectancy and things like that.
Uh-huh.
But they're only doing 20 hysterectomy per year. We
Oh,
do 250, they do 20, all right? Now, what
wow.
about UK and New Zealand? All English-speaking countries. So historically, these countries are very similar. Even you look at the national flags, they got the Union Jacks on it. So they're very similar. And yet, UK and New Zealand only doing half of the hysterectomy that we do in Australia.
Oh, wow.
Then you got to ask why that's the case, all
Yeah.
right? So and obviously the health systems are very different. Australia is very much fee for service, and in New Zealand and UK, they have, especially UK, they got NHS, which is socialist medicine. So that's somewhat different. So going
Mhm.
back to answer your question about why it's underutilized, number one, I think for adenomyosis is still relatively new. Number two, the referral pathways to the gynecologists, and they're not familiar with this procedure, and certainly it's not a procedure that they do. And some people say, oh, why can't they learn to do this? It is a very different discipline. So we train as a radiologist, we trained as an interventional radiologist. We work with the blood vessels, we use catheters. That's what we do day in, day out. So even
Okay.
though it's a simple procedure, but you want to do a simple procedure well.
Okay.
Okay.
That's
So
right. Yeah.
you said doing hamburgers is not hard. Everybody should be able to do it, but you do it like McDonald's. So methodically, it doesn't matter where you go in Miami or in Seattle, the burger is exactly the same. To
Yeah.
do that, you need to have good training and you need to have a system. So you can't be dabbling on this.
Oh, okay. That gives me a lot to think about. Uh,
Yeah. So following this paper, so some people say, all right, it is good for short term, but is it good for long term? So
yeah.
we follow the same cohort of women for up to 5 years.
Okay.
And we published this year. And so we published this year, 2021,
21. Mm-hmm.
the long-term durability of UAE for adenomyosis, the same cohort of women, but followed for 5 years.
Okay.
And so the recurrence rate is 10%.
10%.
Okay. So
Okay.
is that good or bad? Okay. I think it is good because our threshold for recurrence is very low, meaning that if they say, oh yeah, it was fantastic, it was lighter than normal, but it is still heavy, it's a bit heavier now than what it was initially after the procedure, and that triggers a recurrence.
Okay.
If they say,
Okay.
I was fantastic for the last 3 years, but now every now and then I have to take a Nurofen or so, and then that's a recurrence for us.
Okay.
Okay, so
Okay.
we have very low threshold as long as they go back a little bit, so we call that a recurrence. Now, the other way to look at how durable this is to look at the hysterectomy rate. Remember I said initially we were able to save, the hysterectomy rate was 5% initially at
Right.
22 months follow-up. And this is at 5 years, the hysterectomy rate increased only by 2%.
Oh,
So only about 3 patients, extra patient had hysterectomy in the subsequent 3 years.
well, that's
So
really,
yeah,
really good. I
so
looked at that as really good.
yeah,
Yeah.
I think that's pretty good as well. I think you have a medical background. You work in the lab, right, Maria?
Yes, that's right. Yes.
Yeah. So you learn to do critical thinking, analysis of data. So that's basically that's your day-to-day work. You know, when
Right.
someone say something to you, you say, hang on, wait a minute, let me look at the evidence. And this
Exactly.
is the so I think it is pretty good because if you look at that, so we're able to save so many women with hysterectomy, from hysterectomy. So with the key is that this is a minimally invasive, um, non-surgical procedure. It's non-hormonal, so it does fill the gap between Marina and hysterectomy.
Yes. Yes. And one of the things that I really like about it is it's non-hormonal.
Hmm.
Um, I've done a lot of research, and I'm really thinking that, this is just from things that I've read, but I always think that it's might be the environment that might be at play here with adenomyosis, with the xenoestrogens and
Hmm.
things like
Yes.
BPA and phthalates and all of that.
Hmm.
And one of the xenoestrogens are birth control pills, and that's one of the main ways that we treat adenomyosis is through birth control pills. So it's nice to have an option to treat it with um,
Yeah. Yeah.
something that's
And
non-hormonal.
when I was researching for my book, Maria, and birth control pill is very commonly used to treat adenomyosis, related heavy bleeding, but
Mm-hmm.
there's no study that has specifically designed and to evaluate the use of birth control pill, or in other words, combine oral contraceptive pills to treat adenomyosis. There's no evidence to show that it actually works. There's no direct studies on that, which I haven't found. Maybe you have found.
No, actually, no. I know that I went through adenomyosis for 17 years, and that was my only treatment was the birth control pill. And a lot of the women on the support site, they talk about it all the time. The doctors are always throwing the birth control pills at them.
Yeah,
Um,
because the thing is, if you go to a GP or gynecologist, if you don't want a hysterectomy, really there's not a lot for them able to offer.
right.
And so typically they say birth control pills in younger girls because it seems to kind of regulate the periods. But the big questions we don't know is that the estrogen within the pills, what's that going to do to the adeno?
Yeah,
Are
exactly.
we
Because
just
it's
masking the symptoms?
right. 100% agree with that. And it's an
Yeah,
estrogen dependent disease. So, you keep putting,
exactly.
so
Exactly. Yeah. So the beauty about UAE is not hormonal. So we shut down the blood supply. And yes, we don't know, in terms of fertility, At this juncture, we don't know the answers yet.
Okay.
And but we have some successful pregnancy after embolization UAE for adeno.
Oh, good.
We're not allowed to promote it and to say that this is a fertility and enhancing procedure.
Okay.
So what we can say is a uterine preserving procedure, meaning that there's a high chance to get to keep your uterus. But
Okay.
we can't say whether it enhances its fertility because we don't have the answer.
Okay.
Yeah. So there's a
Okay.
good chance to get to keep your uterus. There's a good chance that ovarian function is not harmed. 97 to 99% of the time, the ovarian function is not harmed. The
Okay.
risk of ovarian injury is only 1 to 3%. And so if you borrow the data from UAE for fibroid, uh, the fertility rate is, the pregnancy rate is actually quite good for fibroids. It's about 38 to 48%
After
after
UAE.
you for fibroids.
Oh,
Yeah,
okay.
yeah. So is that number high or low? I think we got to put things into perspective. Number one, in general population, the fertility rate is not 100%, as we all know. It's
Right.
about 85% in general
Okay.
population. So it's not given a couple can conceive without assistance, right?
Okay. Hmm.
So women with fibroid, quite often they have severe symptoms. What I'm trying to say, the women that needed UFE for fibroid, quite often they had previous surgery, they had other ways trying to treat the fibroids, and their only other solution, and again, is hysterectomy. So they chose not to have hysterectomy, but they also put up their hands and say, hey, by the way, I wouldn't mind having another kid, or
Right.
I haven't had a kid yet. So these is the number where it's from. So these are those UFE performed for women with symptomatic fibroid. They happen to put up their hands and say, by the way, I would like to have another kid. So the result is a 38 to 48% pregnancy rate, which is uh, not too bad, I think.
No, I mean, I would have loved to have those odds when I was going through this. I mean, I went 17 years and we tried for an extended period of time and I was never able to achieve pregnancy. But I wasn't actually diagnosed with adenomyosis until hysterectomy. So, um,
So
no,
they presume probably the ultrasound has somehow missed the diagnosis.
yes, I've had multiple ultrasounds and they always said it was
Yeah.
normal. But that was
The
from
other thing is
1990.
the main thing is the lack of awareness, because ultrasound signs can be very subtle.
Yes.
And so I haven't put this, I will put that on my website. There is a paper from United Kingdom,
Okay.
and it's really good on some subtle signs, ultrasound signs of adenomyosis. I've
Oh,
actually
good.
made the infographics, so I'm circulating that. I'm running a sonographer's tea room campaign at the moment in my local area.
Okay.
So we're sending them out this book.
Oh,
Can you
good.
see? Yeah. I've given out the book, and I also made an infographic, and to basically raise awareness, to remind the sonographers to pick up those subtle signs. The message is that if you didn't pick up these adenomyosis, there's a severe implication to the potential long-term quality of life of the woman that you're scanning, in terms of the treatments, the treatment choices, and the fertility potentials as well.
Okay. That's an awesome thing to do. I I'm thinking about the United States. I think at one point on my support group site, somebody asked you about, getting a UAE in the United States. And you mentioned teaching hospitals, and I didn't even consider that. But I'm thinking like universities over here might be.
Are you in DC?
Yes,
Okay,
yes.
so you must look this guy up, Dr. James Spees,
Let me write him down.
SPI. Yeah, James Peace, and he did Condoleezza Rice.
Oh, is that right? Oh
In
gosh.
2000, I actually had the opportunity to meet Dr. James Peace when I was visiting DC in a radiology conference. And now I
Uh-huh.
actually went to see him I went to the conference. It happened to be in DC. So I emailed him. I said, James, can I come and see you and visit you? He's at Georgetown
At
University.
Georgetown. Yes.
Yeah.
Yes.
James Spees is phenomenal. He's published so much on fibroembolization.
Is that
Yeah.
right? Oh,
And
wow.
so I met him in 2000, and his wife is a gynecologist. He's an
Oh, my.
interventional radiologist.
Wow.
So I guess that's probably why he's interested in women's health. And he's doing a lot in the early literatures about fibroembolization. I think 50% are from James' department in
Is that right?
Georgetown.
Oh,
And he Condoleezza Rice had heard fibroembolization in 2004,
okay.
and she had a procedure. Obviously, she just before she became the Secretary of State.
Oh,
So she obviously was a busy woman, and she can't afford the downtime. So James did the UFE for her on a Friday afternoon,
uh-huh.
and she went back to work for George Bush on Monday morning.
Oh, my goodness. Wow. Well, I have to look him up. Definitely. I will definitely
James,
look him up.
yeah, but James, he's aware of, he has so much publication on fibroids. So, and he's a very humble person, and so I think most of the fibroids issues has been sorted out. So he's probably focusing on other issues, and the most of the adenomyosis paper, some from Korea, some
Uh-huh.
from the Netherlands, and some from UK. I think probably in the state they have a few paper as well, but I can email you later the people that's interested in adeno in the US.
Oh, that would be
Yeah,
great. That would be great. I'm sure the women on my site would love the names of some good, good places they
yeah,
can
yeah.
go for
Yes,
this.
yes, yes, yes. I'll see what because we haven't been meeting these people for the past 2 years, and UCSF and Robert, she does a lot of fibroembolization
Oh,
uh,
okay.
in on the West Coast,
Okay.
and yeah, I'm sure that most of the major teaching hospital, because interventional radiology in the United States is very strong. It's a
Yes.
very strong fraternity there, and they've been developing this, pushing this for the past 20 to 30 years. And of course, the main thing is they're trying to treat is vascular disease and cancer therapy. So that's their main areas that they
Oh, okay.
do. Women's health certainly and should be. There's quite a few big names from United States, from Canada,
Okay.
treating this. Yeah,
Okay. Yeah,
we
that'd be
can. I can give you
great.
the names later on. Yeah,
Okay, that would be awesome. That would be great.
yeah, yeah.
Uh, I'm trying to see if there's anything else. Um, let me see. The, okay, this is one thing that I've seen on when some of the women that have had UAE, they say that the pain is really bad after this. And I know you
Oh yeah,
mentioned this earlier, but
yeah,
can you kind of talk about that a little bit? Because I think
yeah,
a lot of women they turn away from UAE because they keep hearing these horror stories.
yeah. And the pain is cannot be worse than major surgery, I don't think. Yeah. So the
Okay.
pain is because of lack of oxygen, and uh, so can you actually you can see my screen? You can see me
Yes,
or see my screen at the moment.
I can see your screen and
Uh,
you both.
okay, good. So so the two issues here. Yes, there will be pain, and it's like anything biological. It's all bell-shaped curve, right?
Okay.
So most people have moderate pain. So I tell my patient the pain we expect is somewhere between 4 and 8. Some people say, oh, I get my period pain 8 out of 10, 9 out of 10 anyway, so it can't be worse than my period pain.
Okay.
That's true because so most people get moderate pain. You get outliers. So some of them say, Dr. Liang, you said there's going to be pain. I didn't have much pain at all. Is it going to work? I said,
Oh,
yes. And the
mhm.
effectiveness is not related to how much pain you have. All right.
Okay.
So
Okay.
we have outliers. There will be a few patients, they have quite significant pain.
Okay.
So we don't know who's going to get a significant pain. So we pre-treat everybody, and we prepare them for the potential worst pain they're going to have.
Okay.
All right. For UAE, as I say, it's been on for 25 years. UAE for adeno has been around since early 2000s. So over the past 20 years, there are small incremental improvement in pain control.
Okay.
Okay, so number one is non-steroidal is very important. So we find Voltaren suppository is very helpful.
Okay.
And the other thing important that is a study from Korea that we give a patient a dose of steroid, okay, dexamethasone. And
Okay.
that's very commonly used for oncologists for cancer treatment for patients going through chemotherapy, because when you when the cells are dying, it releases chemical that make us sick, make us unwell, and the inflammation will cause pain. So if we pre-treat the patient with some steroids, not for long term, just for me, I'm just giving them 5 days. The Korean paper only give them 1 single dose. So that helped with the pain. And the third thing I think is very important more recently is the use of intra-arterial lignocaine or lidocaine. And towards the end of the procedure, you just inject a small amount of lidocaine into the artery. And that can, so all these combinations have significantly improved the pain control.
Okay.
In
That's
some
good to know.
centers, they also do nerve blocks, which I don't use because I didn't think it's necessary for my patients. But in some centers, they do nerve blocks, and that tend to work quite well as well.
Okay. Okay, that's good to know. Yeah, I mean, I think like you said, between a most are between pain level of 4 and 8. I think that will make these women feel better, because I did a survey last year and asked them what their pain level is, and a lot of women said 15, 20, or over 10, so a 4 to 8 that's actually a good thing. So
yes, yes. And the other thing, we give them patient control analgesia. Say they've got a button to press every 5 minutes. They don't even have to call the nurses overnight. That's helpful.
Oh, that's good too.
What we call patient control analgesia.
Yeah, I've heard of that. Yeah, that's good. Okay. Let's see. I had put down some notes, and I'm just going to make sure I've covered everything.
Take your time. Yeah.
As far as the junctional zone, in my research, and like you said in your book, that it's diagnostic for adenomyosis is the junctional zone is greater than 12 millimeters. Is that right?
Yes.
But whenever I see like some of those pictures that you've shown, the difference between the two sides of the wall, like one side will be thin and the other will be huge. Which do you think is more informative, the wall, the difference in the wall thickness, or the fact that it's greater than 12 millimeters? I'm just curious about that.
Okay, so that's a very good question. So that goes back to adenomyosis diagnosis, and we're just going to go down to adenomyosis. I'm going to show you if I can shrink that a little bit so I can find where my things are. So I'm going down to the adenomyosis block. All right.
Okay.
In the block. So here's this block here. How do we diagnose adenomyosis and why are we missing it? It's actually similar things from the chapter there. So okay. So maybe we talk about a little bit about ultrasound first.
Okay.
Okay. Ultrasound, typically you see asymmetrical wall thickening, as you can see in this case.
Okay.
Yeah, I'm going to make it larger. Yeah, you can see this is the endometrial cavity there.
Okay.
You can see this wall is the opposite wall is far thicker than this wall.
Yes.
And the other thing, ultrasound typically, this is a classic sign they call the venation blind artifact.
Yes.
Do you see that?
I see that.
That's because of the microcyst. So that's all that interfere with the sound transmission. You have this venation blind artifact.
Okay.
Now, the other thing is important for ultrasound is you don't see this very often, but once you see a single cyst, that's diagnostic. You don't expect a cyst within the uterine-muscle wall. If you
Okay.
see a cyst, that's adeno.
Okay.
No other differential diagnosis. Now,
Okay.
for MRI, the positive signs are you actually seeing the abnormal signal in
Yes.
the wall. Okay. And obviously the junctional zone thickening here
Yeah.
is very obvious.
Very
Okay.
obvious.
Now
Okay.
the beauty about MRI is it can tell very easily what is fibroid,
Okay.
all these fibroids, and what is adeno
Ah,
here.
yes.
You can see this cyst here. You can see a fluid level as well because the lady has been bleeding into this cavity. No wonder she had premenstrual severe period pain. You're bleeding
Oh,
into this cavity yourself,
wow.
right? They had bloating as well because the gland started to swell up before the period, right? In the second half of the period, the endometrial lining thickens up,
Uh-huh.
but this is in a confined space. And guess what? They get bloating, premenstrual bloating and pain.
Because it's
Now,
blocked in there, right?
there's a story behind this picture here. She is a coronary unit nurse, so she's a cardiac nurse.
Oh,
She's 40 something. She's been suffering from heavy menstrual bleeding and period pain for 20 years. She had
oh,
numerous surgery. She had numerous laparoscopic surgery removing her fibroid. She had multiple hysteroscopic surgery removing whatever inside her cavity, curette, and
oh,
she's not getting better. Why? Until this is done, we didn't know why. Because they always thought it's the fibroid, but the culprit is not the fibroid, it's her adeno.
oh,
These fibroid, I call them bystander fibroids, not the fibroid that's causing the issue, it's the adeno.
oh.
Now, going back to your question about junctional zone thickening. Okay, now junctional zone from 0 to 8 millimeters is regarded as normal.
Okay.
It is between 8 and 12 is equivocal. Beyond 12 millimeter is diagnostic of adenomyosis. That's the criteria people use. But for a small uterus, the absolute measurement does not mean anything. So when the uterus is small, like 60, 80 mil, so you got to take the percentage into consideration. So the junctional zone may be 10 millimeters. It doesn't fulfill the 12 millimeter criteria. But if the junctional zone is, in this case, on this side, is more than 50% of the total thickness, and then the other criteria we use is the junctional zone thickness should be less than 40% of the total thickness of the uterus.
Oh, I see.
Right?
Okay.
And that's one thing. And the other thing is the percentage thickness of the uterine wall, the asymmetrical wall thickening as well. I
Okay.
think I mentioned it somewhere in the in here. For small uterus, absolute thickness is less meaningful, and
Yeah.
therefore other accepted criteria are junctional zone more than 40% of the total uterine thickness, or the difference between the front wall and the back wall is more
More
than
than
50
five.
millimeters. So there are two ancillary criteria that has been proposed.
Okay. Oh,
Yeah.
interesting.
That's for small uterus because
Okay.
the woman do not have to have a large uterus to have this. So the treatment, women I've treated with UAE, they can have a uterus like 60 mil, which is just as normal. Up to last week, I think I treated a record one, which is 1700 mils.
1,700 mils?
Yes, 1.3 kilogram uterus.
Oh my goodness.
So she's probably going to be the biggest one.
Yes. Oh, she must be miserable. Poor woman.
Yeah, she has been miserable. I mean, the key is that, so I hate the radiology say, oh, on the MRI report, mild adenomyosis, things like that. I mean, they haven't got a patient in front of them. So it doesn't matter. The symptom that the lady with 60 mil uterus, her heavy menstrual bleeding and period pain is probably not too different from the lady who has 1700 mil uterus.
Oh,
And so the degree of heavy bleeding and the degree of pain maybe it's not related to the size of the uterus and the extensiveness of the uh,
that's it. Okay.
adenomyosis on imaging. So yeah, and that's, I don't think there's a correlation there.
Okay. Oh, wow. This
Yeah,
is really informative, really interesting.
yeah. So as far we don't have to cover everything in one go. We can pick
Right.
certain areas and have another chat or have another. If you want to
Right.
do a webinar, I'm happy to do webinar as
Okay.
well
Okay.
in the
Yeah, that
future,
sounds good.
or
I
we
know.
can maybe sort of a more focused discussion on different things.
Yes.
I think in your group, a lot of people talk about marina,
Yes.
and that's a hot topic. A lot of people talking about ablation.
Yes.
That's another hot topic.
Yes.
And so certainly, my feeling is that because it's just a way that patients are referred, the referral pathways from your GPs, women's health GPs, and then to gynecologists, and they all talk about, you know, these things a gynecologist can do
Yes.
because UAE is not done by a gynecologist. So there's a huge lack of awareness from GP, from the woman who's trying to get treatments, and that they're not aware about UAE. It's not even in their picture, you know.
Yeah. Yeah. That's what I want to do. That's one of the reasons I wanted to really focus on UAE, especially with this, you know, this time with you, because I want to, after reading that book, I want it to get out there that yes, UAE is a definite
Yeah.
option in
The
treatment.
reason is underutilized is not because it doesn't work. It's simply because of referral pathway.
Okay.
Because like in Korea, it's very commonly used.
Oh,
Okay,
okay.
and the Koreans written a lot about this as well. So
Ah,
it's all about you know being aware of this. We can say this is still relatively new.
mm-hmm.
So we still waiting for randomized control trials to come out. So there is one being done in the Netherlands. And so if they're comparing UAE versus hysterectomy, so
Yeah, that was
that
in your
can
book,
come
I
out
think.
pretty soon. But you know, do we really need a randomized control trials because we're comparing two very different, it's not two different surgeries. It's comparing one which is non-surgical versus one that's surgical. So yes, and randomized control trial would be great, but on the other hand, and I think with the evidence that we have at the moment, and I can tell you as far back as 2013, the NICE Institute, which is a UK institute, is called um, National Institute of Clinical Excellence. So
Okay.
it's like a freestanding committee. They evaluate treatments. Okay,
Okay.
for
Okay.
they evaluate new treatments, they compare treatments. So back in 2013, NICE or NICE Institute from UK already recommended UAE for adeno as an alternative to hysterectomy. Even as
Oh,
far back as 2013, they thought there's enough evidence to suggest that these actually work for adeno, and it should be offered to women who prefer not to have a hysterectomy.
interesting. Wow.
Mm.
Uh, uh, well, we just got to keep on, you know, fighting our way through this and try to get the
Yeah,
attention. These,
I think so because you know it's sad to see and these you're not. I mean, I've sometimes I look at the other support group just to see what the women are talking about, what their concerns about, and things like that. So there's
yeah.
an Australian, New Zealand support group. There's a UK-based Adenomyosis, a WISE
Yes.
support group. It's
Yeah.
really, it saddens me. It really saddens me to see that this support group has become a hysterectomy support group.
The what? My support group.
No, no, no. I mean the
Oh,
others.
The other ones, yeah, there's a lot of discussion about hysterectomy, and especially in the United States, they just, the ones that, the doctors that I've seen and people that I see talk on my site, they're just like, well, we can't do anything. You just need a hysterectomy. And um,
Yeah.
it
So
is sad.
it is sad to see that I thought, this support group to support women, to arm them, to empower them with knowledge.
Yes.
At the end of the day, it's individual choice.
Yeah.
Okay, we all
Mhm.
have to choose. The doctor's job is to offer women the options. So our clinic, we base on, because I run the clinic alongside gynecologists. So we are quite different. We're running a multidisciplinary clinic. All
Oh,
right. Yeah.
yes.
So when I consult in my room, my next room with a gynecologist. I
Okay.
do that at 4 different sites
Oh, wow.
because a bit of disclosure, I was trained as a diagnostic radiologist, and I become an interventional radiologist about 20, 25 years ago
Okay.
because I'm not satisfied by just looking at the picture. So I want to do
Okay.
something about it. So I was really excited. I'm able to save life, treating trauma patients and treating postpartum hemorrhage. I'm able to extend life by giving people, more life by treating their cancers.
Yes.
Maria, it's just not until I started doing women's health, which is about maybe 15 years ago, that I realized how important a quality of life to a person than just to give them another 6 months or 12 months.
Yeah.
And women so much appreciative. The reason for this is because you really, I mean, yes, if I make a diagnosis of a cancer, I give another cancer patient for or another 6 months, or I save someone's leg. It's not the same as the woman come back and say, "You changed my life,"
Yes.
you know.
Yes.
And this was amazing. Um, I got women 40 something years old. They had their first period when they were 12 or 15, and they
Okay.
said, "I didn't know the period doesn't have to be painful."
Yeah.
They just didn't know that. I
Yeah.
thought that my period was normal. So now when we come back for follow-up, basically we give them five questions. What's your period like? Back to normal, lighter than normal, light as ever, or heavier than before?
Okay.
Quite often you get the answer, it's the lightest period I've ever had.
Oh, I
You
mean,
know,
that's miraculous. It really is. And
that drives me why I'm doing this.
yes, yes, yes. And I'm going to tell you, Dr. Liang, I'm speaking on behalf of all the 13,000 members I have in my support group. We are so incredibly thankful for people like you that are fighting for us. Because I mean, when I went through it, there was just nothing. That's why I started my support group. I couldn't find any information. I didn't have anybody to talk to. And now we have people like you that are really working to help us. And you just have no idea how thankful all of us are.
Now the thing, Maria, I for me the job is not done until the women are aware of this. See,
Yes.
you said that 15, 20 years ago you didn't have any other options.
No.
I have a clinic on Tuesday. I bet you on Tuesday there will be a couple of women say, I've been to 3 gynecologists. They all say hysterectomy is the only solution. So
Yeah.
that's the problem I'm facing still.
Yeah.
Okay, so even though I've written in their journals, and those journals are showing you are Australian, New Zealand Journal or ONG. They
Yes.
are in their journals, all right? I didn't
Right.
publish in my radiology journal because it's pointless. I published in the gynecologist journal. So you assume they know it. And then again, if you go to my doctor's resources, I've written in the GP publication as well twice, not only once, because there's 2 major ones in Australia. One is called Australian Doctor that goes out to almost every GP. The other ones we call Medical Republics, and that also goes to almost every GPs. I've done in both. And it's not changing anything. It's not changing the phenomenon. So that's the reason I said I have to
To
address
write.
this
Uh-huh.
to the women themselves,
Yes.
because women they more than 50% of women, they weren't referred by the gynecologist or GP. They found me online. They
Oh,
Google it because they said there has to be something else, and there has to be an alternative. Or because Australia is quite multicultural, they got their links elsewhere. Like Korean women, they come to see me because on their Korean website information, or oh, this is funny. I see a lady from Peru. She hardly speak English, and she came to see me. I said, "How did you find out about me?" He said, "Oh, on my Facebook group, Spanish Facebook group."
oh, is that right? Oh,
Now, this is, I think, it's kind of amusing, but if it's sad.
it is
To me,
sad.
it is sad.
Yes,
And so there's a lot of work for us to do to I think for us is to empower the women, to give them the knowledge, to give them the evidence, then let them choose what's best for themselves.
I agree. I agree. And that's why I'm hoping, that's why I wanted to record this and then put it onto my site so all these women can see it and,
Yeah,
educate themselves, about
sure.
this. So you
Yeah.
might get inundated with a lot of messages after this.
No, but no, maybe let's do a webinar at some stage if you want.
Okay, yeah, let's do that. Let's do that.
Yeah.
So
And
everybody can get
I
their,
think, yeah, I'm getting a lot of interest from the US as well. Yeah.
okay,
Yeah. I
yes.
mean, in terms of, yeah, that's good. Yeah. Thanks
Okay.
very much. I'm so glad to have you to drive this. I wish you live in Australia. You
Uh,
know what? If you live in Australia, then what I was proposing to do is to set up a NGO, a not-for-profit organization. In Australia, we have endometriosis Australia, we have diabetes Australia, Alzheimer's Australia.
oh,
Guess
yes.
what? We don't have adenomyosis.
Adenomyosis. Yeah.
Yeah. So I need someone like yourself, who has the energy, have the passion. And so if you come across an Australian woman, send her to me.
Well, I was going to tell you, I have a lot of women from Australia that are in my group. So you never know when they see this, they may contact you. So anybody that sees this that's in Australia that wants to help out Dr. Leanne,
Yeah, I think
please.
we are getting some tractions, like this lady, Emma Hurst, who wrote the foreword for me.
Oh, yeah. Uh-huh. I remember. Uh-huh.
She's New South Wales member of parliament.
Oh, oh, yeah.
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 Yeah, she suffers both adenomyosis and endometriosis.
Oh,
So when she saw this, she's happy. She said, "Yep," and she even passed sort of raised a few motions in the parliament, raising the awareness about adenomyosis as well.
oh, that's awesome. Oh, that's
Mm,
great.
yeah.
Well,
All right. Good.
um, so I'll keep in touch with you. And then if you would be open to talking to me about other things, like the Mirena and the ablation, I failed an ablation and did some research on that and found out that, ablation is generally not recommended for women, especially with the deep adenomyosis. And,
Yeah,
so
that's right. Because ablation, you're only treating like 2 to 4 millimeter thickness of the uterus.
yes,
If you think about the definition of MRI diagnosis, you need to be 12 millimeters. So
right.
you're only ablating a superficial layer, and the deep layer is not treated.
Oh,
Right?
that makes
So
sense. That's why.
even though you might have eased your heavy period, but period pain can be worse. The reason for the period pain is worse because you're sealing off more glands.
Oh, that makes
You,
sense. So
you
it's,
see? Yeah, you're sealing off more glands, and so let's go to adeno. I do have an illustration there, so you can see this one here. So basically, ablation uses a device you insert into the cavity, then you hit. But the device is for safety. You don't want to hit too deep. All you need is to get rid of a thin lining, which is about 2 millimeters, 2.5 millimeters. All right.
okay.
If you go too deep, it can damage other tissue. So it has to be shallow. All right. And
Oh,
to ablate the endometrium, you don't need to go deep.
Okay.
But on the other hand, if you don't go deep, you're not going to treat the adenomyosis that's inside the muscle wall.
Right.
The pain's worse because you're sealing off more glands.
Okay.
Right? So I'm recruiting some young doctors who might want to have a line on the CV to write it up, because we have a small case series of women who has gone through ablation and but have worsening of period pain and subsequently treated with UAE.
Okay.
So my impression is it works for the pain, and that's post-ablation.
Oh.
So yeah, so you can see that's why the pain can be worse.
I see.
Yeah, there's a problem. There's a huge problem here with ablation, because at the moment the device company has not put adenomyosis as a contraindication for the procedure.
Oh, really?
So that's why the gynecologist knowingly or unknowingly using endometrial ablation to treat adenomyosis, and that can potentially cause more pain. And
okay.
if the device company, if they know adenomyosis should not be treated with this, and they're not warning the clinician, that's a potential for class action in the future.
I was going to say, I mean, that needs to be put on as a contraindication for sure. I don't see how they're not getting sued over that.
We need to get our paper out because we need to do our bit. We need to be in the literature. Otherwise, the companies say, hey, where's the evidence? You know, we don't know about this. You know, someone hasn't written about this. How do we know about this? So that needs to be raised. But it's common sense. You can see why it shouldn't work. Because by going to your support group, we know that many women gone through this, it didn't work.
Right.
Yeah. So so it's not hard to understand why it didn't work.
Right. It's pretty clear to me.
Because I'm trying to be more gentle. My gynecologist associate, Dr. Bevan Brown, he quite often say, what do you do with barbecue, right? How do you seal the juice in? It can be offensive to vegetarian patients. So I've got to be, I say, you've got to go, Dr. Brown, you've got to be careful. You need to be correct. The patient can be a vegan. What are you talking about? He said, but most women will laugh. It's like, yeah, I get it, because you want to seal the juice in, so you seal the surface of the steak. And that, of course, the pain can be worse.
That's funny.
It's funny. He's Dr. Brown. He's really great. And so he's straight shooter. He just, he doesn't go around corners. He says whatever he thinks is right. So his part is basically, very practical advice to women how to deal with various things. My narratives are boring bits, it's all evidence-based and kind of the narrative, it's not really my opinion, it's what the evidence is out there, is in the literature. So that's my narrative. And of course, the women's stories to illustrate, like yourself, what they've been through and suffering this disease. Yeah.
Yeah. Well, I think you've answered a lot of questions, and I think this is going to be a really informative video for a lot of women. And I want to thank you for taking the time, to speak to me about this.
It's a great pleasure, Maria, and nothing excites me more than talking about adenomyosis, to be honest.
Okay.
So I don't have a boring life. I do have other things in life.
Yes.
I mean, I play tennis 3 times a week. I go sailing once or twice a week, and I run an interventional practice. But nothing excites me more by talking about this, I must say.
Well, thank you very much. Thank you. Yeah. We just can't thank you enough.
That's fun. All right.
Whoever's watching this video, check out this book. It's available on Amazon. I've read it, and it's just, it's so worth the money. You just learn so much from this. And again, Dr. Liang, I want to thank you for writing it.
It's my pleasure, Maria. It's great talking to you.
You too.